Welcome, SLP215. So last week, a couple different things. There was two little things I want to review because a lot of people did miss it. So let's be clear. So aspiration. So when we're talking about aspiration, when we're referring in a feeding and swallowing standpoint, we are talking about food going in, food or liquid, I should say, going into the lungs. So a lot of people said larynx, or there was some other verbiage used, and most of you had the right idea, but really what we're really looking at is something foreign entering the lungs. So you can aspirate other things like, swallowing something that you shouldn't have. I'm trying to think of other things that people, it's usually little kids that,
a Lego.
Yeah, has something
or earbud.
Yeah, a toy of some kind going in the lungs. So so sometimes you can have something stuck in your throat and it cuts your airway off. And when that can be various things when we say throat, but really what I'm looking for, aspiration is where, foreign material, liquid or food, maybe an object, enter in the lungs. So just be clear, it's more about the lungs, because that's where that pneumonia. So when we're talking about pneumonia, we're talking about I think there's bacterial pneumonia, I think there's fungal pneumonia. And then when we're looking at aspiration pneumonia, that is also another key piece that is dangerous and can be detrimental to somebody's health and put them at risk. So that's why. Now, somebody can have food so let me just clarify too. Just because you aspirate something in your lungs doesn't mean you're going to get sick. And also a couple other people noted, clearly some of you have had people who've had maybe strokes or some other kind of swallowing challenges. And just because somebody aspirates doesn't mean they will get sick. They're just at high risk to get sick. So sometimes looking on the continuum of diet recommendations. So I just had this conversation with my mom. So my brother, he has cerebral palsy. He has been in basically a skilled nursing facility for a long time. Some of that was exacerbated by COVID. And then we couldn't see him. He's got major communication challenges. He doesn't talk. He uses sign language, and he's pretty good using nonverbal ways. I'm always amazed. But his swallowing is really deteriorated, and having the cerebral palsy, I think he's had some mini strokes and things like that. He's weak. He is tube fed, but he was swiping food off other people's plates. And this is actually a few things that, we've had to address it. And let's say we've had kids at school who are fed with a G tube, but they're around food and might be, they're not really safe to swallow, those kinds of things. But I was telling my mom, they're letting him eat a little bit, but I just told her, he's got to have good hygiene. Like, he's got to brush his teeth before. If he drinks liquids, because not a lot of people like to drink thickened liquids, of course. So that can be a challenge. So he wants to drink soda or coffee. And I was telling her, as long as he tries to keep the bacteria in his mouth, because it's not so much the stuff on the food per se, it's the bacteria in the mouth then goes down and then it stays there. And that's the issue. And then that bacteria breeds. And so I was just telling her, I said, he might get pneumonia again, and we have to be prepared for that. But this is where we are with the quality of life. So we were talking about like the cost risks, and I was having that discussion with my mom, and, my brother was going to do it, whether it was doctor approved or not. So at least if he's maybe approved a little bit, they can at least control the environment which he gets it, to kind of minimize his risks. So that's what I was telling her. And that happens. So those are kind of just some things that we really worry about when we're looking at that aspiration pneumonia. Especially a lot of times people who get that or are aspirating, they're in a weakened state for some reason, usually, on average, not always. So sometimes people are you know, they use a G tube for other reasons. But looking at the other key piece too, so everyone's clear, when we are referring to kind of so what a lot of people did is kind of put all of the pharynx, larynx, the trachea. So sometimes there's a couple of people I took off points because maybe you're not real sure. So let's just review. The pharynx is kind of what we call the throat. It's kind of that area leading up to the trachea. So then we have the trachea, and that's that airway. So the windpipe, somebody used that. I was like, oh gosh, I haven't seen that in a while, but that's okay. I just want to make sure you guys are clear on, or when we're looking at, when we say the oral cavity, we're usually referring to the mouth, not really the pharynx. And the larynx, I would say, is more general, and we're really more including the, see, why doesn't it, there we go. We're including the vocal cords in that. So kind of, that's where it kind of does kind of get jumbled. And typically when we're referring to larynx, we're talking more of like a vocal cord, vocal fold component. Pharynx, we're talking more maybe in regards to feeding and kind of the throat, things going down the pharynx. And then when we're really worried about like airway, we're usually speaking of trachea. So it does get jumbled, it does get mumbled. So I just kind of want to review that because it's not always clear. And as I say, we do this fun thing where we use the same term. We have 4 different terms to mean the same thing. And sometimes certain terms can include everything or just only one piece. So try to be specific sometimes in some of those. And then the other key piece to just remember that when in doubt, ask your supervisor. So if you're not real sure what you should or shouldn't be doing, or you're working with a client that maybe has some restrictions, you're working on other skills, but you are concerned about the client's safety, anytime you're concerned about the client's safety for whatever reason, talk to your supervisor. Okay, so this week, module 4. Hold on. Okay, hold on. Can people see that? Yes or no?
No.
Okay, didn't think so. Try that one more time. Now, can you see it?
Yes.
Yes. Yay.
Okay. So voice. So yeah, voice kind of gets, like I said, dysphagia and voice kind of come together a lot of times. Now resonance. So this all used to be in one module, so I'm really glad we divided this up a little bit. So resonance, when we're talking about resonance, we are typically referring to nasal stuff. And please, if you learn nothing else this week, hypernasality and hyponasality. So hyper means there's excessive, there's extra. Hypernasal means there's extra air coming out your nose. Then if you're hyponasal, so when you think about hyponasal is when you have a cold. You kind of, you're not getting air out through your nose and you sound stuffed up. And then there's some other resonance. We talk about cul-de-sac resonance. A lot of times when we have people with a hearing disorder of some type, typically we can hear the resonance. So for instance, I have one particular little guy I work with, and every single graduate student that comes in, or a new therapist or a teacher, they're like, okay, why doesn't he wear his hearing aids? He definitely talks like he has an extensive hearing loss, but oh God, if I send him one more time to the audiologist for his hearing, who he doesn't have a hearing loss, he does not have a hearing loss, but he talks like that. So that's kind of we're talking about resonance. Like there's something, I think, craniofacial wise that's making that. Again, I need an ear, nose, and throat specialist to come and tell me what that is because I don't have the instrumentation to determine that. But I don't know how many which ways of Sunday I keep telling, I said, he cannot produce the right resonance. It is affecting his intelligibility, and it's not because he's got something else. I don't know what's causing it. but I'm guessing it's something physical that I can't get beyond. Okay, hold on. Now let me reshare it. Okay, can you guys see that? The PDF?
Yes. Yes.
Okay, I think maybe I have to download it. Anyway, all right, so a couple different things. Disorders of resonance. So just the review of the anatomy. Let me enlarge this. So kind of review that. And then, hang on, I gotta move my pictures around here. It's the balance. So resonance, the definition of it, it's the balance of sound vibration in the oral, nasal, and pharyngeal spaces. So that's kind of that, what I call the whole head and neck. So resonance is kind of how does that sound reverberate? So in English, okay, so here's some review, 214. What are the only nasal sounds we have? We have N, M, and then the ing, right? The ing sound. So those are the only sounds in the English language that are nasal sounds. And then when we look at normal function of the velopharyngeal port, so that's where that nasal part is, open or closed, is required for good resonance. Okay, and so the VP, so when we say the VP, we're talking about the velopharyngeal port elevated towards the back wall of pharynx, so that's that back part of the throat, sealing off the airflow through the nasal cavity. So changes in resonance, so this is what I keep trying to explain to this particular student's mother. Changes in resonance can be caused by obstruction, malfunction, or malformation. So sometimes an obstruction, that's a surgical thing. That's I have mucus, I have illness, I have a craniofacial issue, also malformation, or it could be other tissues. So it's not necessarily, it's more about extensive tonsils and adenoids. Tonsils and adenoids that are so big, it definitely changes the resonance. And then malfunction, sometimes we have a velopharyngeal port that doesn't open and close. And that can be a real challenge. So you kind of can look at the velopharyngeal port during breathing. So here we go, malfunction or malformation. So we look at like insufficiency. Is there a structural defect that doesn't allow that velopharyngeal port to move? Incompetence, is there a physiological weakness? Is there a paralysis? Is there something other neurological that's impacting it? Mislearning, is it just an artic issue? There is sometimes, again, that's for your supervisor to determine, but I do think disorders of resonance is hard because you usually really need to be with the team. Like speech therapists independently, usually you need to have a very good extensive what I would say ear, nose, and throat specialist look at you to kind of give the input on that. We can make some educated guesses, we can have some good ideas, but really you need to look at that ear, nose, and throat specialist kind of giving some of that input. Common causes of velopharyngeal port issues: cleft palate, apraxia of speech, submucosa cleft. So that's probably one of the most misdiagnosed or underdiagnosed, or I should say underdiagnosed cleft. Enlarged adenoids and other neurological disorders. So definitely there's a neuro component that really requires a doctor. So again, looking at submucosal clefts, bifid uvula. What's funny is I do have a bifid uvula, and I do not have a submucosal cleft, which is what I'd say that's not usually there is, but mine, and it kind of is semi-attached. So there's like two hanging pieces like this kid, but it's like, it's attached right at the base. So the base is attached and then it comes apart. So it's so funny. I remember I did not know I had this until I went to my undergrad, and we're learning, time Indiana University, they taught you how to do oral MEC exams as part of screening processes for bachelor's level therapists. You know, things have changed since then. I didn't even know this was could have been an issue, but I think because at the base it's attached and then it kind of comes apart. So it's right at that base and then the two parts hang down, but it's attached right at the juncture. So it's almost there. And then, so enlarged adenoids. So when you look at where this adenoid tissue comes, it really can affect speech and language stuff, speech and some of those sounds. And then sometimes, again, when you have impaired speech, then that acquisition of expressive language. And definitely speaking to when you have something structural, a lot of times therapy can't help it, not usually. So looking at normal tonsils and large tonsils, and then all the other things, and not to mention, I can go on and on about how much enlarged tonsils and adenoids can affect a child's overall health, and an adult's for that matter, as well as looking at sleep deprivation, poor sleep, and then looking at the neurological components of poor sleep for long periods of time, or then maybe some what I would call anoxic or very low oxygen levels on a consistent basis. So to me, I think tonsils and adenoids is also the #1 undertreated major issue for our children. With allergies and things like that, I think I don't know, I feel like it's a requirement to see an ear, nose, and throat specialist, especially if they have this and extended. So someone's who had, and I know they don't always like doing it, but I think if you're going to get your tonsils out, you need your adenoids out. You get your adenoids out, you better get your tonsils out. I feel like just always needs to go together. So you could kind of look at some of those impacts. So definitely nasal emission or hyponasality. And then that cul-de-sac resonance is kind of that muffled resonance quality. A lot of times too, our clients with the hearing impaired, because they don't hear it, can have that cul-de-sac resonance. And then, abnormal dentition and occlusion. Then there's a whole school of thought of like lip tie, that kind of thing. Definitely, there are some structural things that can impact speech, impact intelligibility, as well as definitely resonance that is a lot of times out of our control. That requires some other medical intervention. And then hopefully we can help support them after they've had the appropriate medical intervention needed. So, and other times too, sometimes sounds were like what we would call mislearned or learned, what I would call idiosyncratic. So they learn how to say a sound with nasal emission for some reason. And that sometimes I see that in bilingual speakers. Just I've noticed that because some other languages have that nasal emission piece, that nasality piece to their sound system. So definitely that can also be a factor. Not that they're going to have an issue, but just sometimes that those nuances with the nasality sometimes are what I would call our bilingual speakers or our English language learners sometimes can struggle with that. And certain vowels have nasality based on their position too, if you really want to get technical. And the other key piece too, that when we're looking at somebody that maybe has some impacted what I would call structural resonance issue, I also think they do have a decreased mean length of utterance. So when we're talking about they don't have sustained airflow in order to say a longer sentence. That's my issue with the tonsils and adenoids too. A lot of times these people cannot maintain like running, physical activity. They can only say 2 or 3 words without being out of breath. And it does impact their language and their intelligibility. So just some other things. Hyponasality, blockage, swelling, enlarged. Deviated septum is also another thing too. So let's say they've had, injuries of some type that can all of a sudden, they didn't have it, now they do. Why do they sound this way? A deviated septum can also kind of cause some issues with resonance. So all of those things can be impacting their ability to be understood. Yes, there will be some. You should really be familiar with anatomy. It's a lot of the whole component with resonance is required on anatomy, because she asked if there's going to be questions that focus on anatomy. Yes, there will be some that ask that. So be familiar with tonsils and adenoids and where they are. Hold on, let me stop the share. And I'm going to share one more on this. So your read and review page, there are some videos. There's a great Asha link. Let me make sure it's still working. Yes. So you can kind of read through that. And what I would call, it gives you kind of a nice summary. And you can look at treatment too. A lot of times, and this is what I want to say about treatment, really a lot of times that requires other medical intervention, and SLP is usually not the only person involved if they are seeking treatment. And definitely looking at, like, do they need surgical management, prosthetic management, pharmacological management, i.e., extensive allergies, they constantly have swelling, that kind of thing. Does that require other kinds of intervention, not necessarily taking the tonsils and adenoids out? And then behavioral. So a lot of times we're kind of that last piece. And you could look at some of the surgical management, and this is usually what we're looking for with people with craniofacial issues or some kind of disorder, cleft, those, various levels of cleft palate. Definitely some things that surgically are done. And then the hyponasality, sometimes they might become hyponasal. Yeah, nasal polyps too, I think, are a little underdiagnosed, and other parts. So when we're looking at some of these atresias, and when we say atresia, it's usually kind of like closed. So sometimes people are stenotic nares. So sometimes people have disorders of the nose, those, what we say, conal, so kind of those turbinates in your nose are closed, whatever. I've had one person I treated who had that, and we just couldn't get the resonance perfect, and maybe only a speech therapist would have noticed some of these things. But he did have a lot of extensive surgeries on his nose, and with his, he had, like, I don't know, I want to call it bone cancer. They don't call it that, but that's like what it was like. And they had to remove it. And it was rough for this particular child, and he was young too. So, but he had a lot of previous surgical, and he was in that final, and then we were kind of working on some other strategies to help him be more intelligible. So yeah, a lot of times the intervention for this is not just speech, it requires, and if you feel like you need some support or more help and guidance, because sometimes, a lot of times they want to, so I have someone who's hypernasal and we're going to work on stop consonants. Okay, well, just because I work on it doesn't mean it's going to sound better. And that might need some other intervention. So sometimes they'll try behavioral as a, let's try it before we do more invasive testing to see if something's wrong. I'm not really a supporter of that. So, or if they're showing some muscle weakness. A lot of times with resonance, and we haven't really talked about, I think you talked about dysarthria in 214, I think. I may be misquoting the class, but dysarthria, definitely you see those resonance issues because they have weakness, usually in the palate, or what I say, the velopharyngeal port, so that they have kind of some either insufficiency, so either it doesn't move or it moves too much. So we definitely can see some of those components. So I'm gonna talk about treatment, and I kind of discussed it a little bit, but we've kind of jumped around a little bit in this. So treatment and resonance, a lot of times we have surgical intervention. So the palate malformations and repair Obviously that's surgical, that's medical, that's doctor, and it's a pretty common thing. When I say common, it's probably one of the major craniofacial challenges that occur. And really it requires a team. So a lot of times what you'll hear, you will hear them, they follow the craniofacial team. So I have one particular delightful girl, and she had Pierre Robin, which is a craniofacial issue, and she's had a tongue resection, she's had a whole jaw thing, she's had all kinds of what I would call jaw surgeries, and she doesn't really have implants yet because she's too young, but she's gonna probably have a lot of teeth implants. She's had a lot of teeth pulled, teeth misaligned, etc., coming out of, the woodworks. So she's followed, and she sees the craniofacial team, I think, every 6 months. So she has to go to the Phoenix craniofacial team, and that's kind of why I follow her, just to see. She's been pretty good. She hasn't needed speech, but if we come to a point again she needs it, or they've done another change and we think we can improve, then we do that. So yeah, it's usually like an otolaryngologist, an ENT, a plastic surgeon, pediatric dentist. So they're usually a part of a team. They have something major. And usually speech therapy is effective for mild disorders. A lot of times surgical intervention is required for velopharyngeal insufficiency due to malformation or malfunction. There are some things called like a pharyngeal flap, a sphincter pharyngeoplasty. I think I said that right. But really, a lot of times they do that surgical, and sometimes speech is required before it as well as after. So a lot of times we're just a step in the process. And really cleft palate. So they have made so many improvements though, depending on the palate, depending on the degree, depending if they had a cleft palate and lip, or, cleft lip is like, whew, that can be fixed pronto, and pretty mild. So definitely sometimes there's usually 1 or 2 surgeries with a cleft palate repair, depending on the degree. And really no, speech therapy can never change the structure of it or the malformation. We can help with maybe some insufficiency or mislearning. But yeah, even sometimes insufficiency therapy isn't going to help. Or they physically can't move their velopharyngeal port, so it's always going to be hypernasal. There is some of that, but again, that's where the neurologist, the ear, nose, and throat specialist, they give us that input. And when is it good for it to get speech therapy? When nasal emission is mild, or then we have other disorders of articulation to compensate, or sometimes if it's just phoneme specific. So sometimes we get like I said, and I call that more mislearning. They accent a sound, make it nasal when it doesn't need to be. And a lot of times it's a sound in their own language repertoire. So, and then auditory feedback. So a lot of times too, just helping them hear what they sound and learn how to adjust it. Definitely something. So kind of be familiar with that. So we have that feedback, that visual feedback, tactile, kinesthetic feedback. So how do we show them that the airflow isn't right? How do we get them to feel the difference in their bodies? And that could be challenging for a variety of disorders, feeling the difference or feeling that oral airflow versus nasal airflow. So there's some techniques in there, be familiar, and there's more. And instrumentation is getting better too. Granted, we don't always have access to that right away. Just some things. Just know, blowing or sucking exercise don't necessarily impact speech. We might do some blowing, and I don't want to say so much more blowing versus sucking exercises. The blowing is sometimes for them to understand airflow. It's more for the conceptual component, not to actually improve the function. So like oral airflow, when I was talking about like helping a kid understand how to get the, like blowing up a balloon, having a kid try to blow up a balloon so they can understand getting the air out and they can visually see it, but it's not going to necessarily improve their speech. So just know, sometimes we might do some, what I would call oral motor exercises, not really for anything other than to understand airflow. So I've done those for them to understand oral airflow versus nasal airflow, but we know that him just blowing a balloon isn't necessarily going to improve his speech or ability to do a nasal sound or not. So it's a lot of times I would say we use maybe those for a conceptual component versus improving the function. So just know, because resonance is kind of that gray area. So if you're working on hypernasality or hyponasality and you're doing some of these exercises, or your supervisor recommends you to do it, be sure you're clear on those nuances. And really, truly, we should see progress quick. And if we're not, then probably they need some other surgical and other medical professional team members to support that particular client. So give you some strategies there. So this week, resonance is hard because I feel it's kind of that one nuance that kind of can come up, but it doesn't really, it's not like that's an everyday thing. It's not like that's something you're doing on a regular basis. You have one every couple of years. Like my one girl, but she's had, and a lot of times there's nothing I could do. So we just wait to see what the craniofacial team recommends. So there's a resonance treatment observation, a resonance quiz, and then a read and review. So on the read and review, you've been given what's the goal. The goal for this client is the following. So client will produce stop consonants with appropriate oral airflow. So what are some strategies? So what we're looking at in the read and review, so look at what the videos, review kind of the information. How are we going to help them develop that and use the consonants correctly and kind of hearing the differences? So a lot of times too, we have to work on that discrimination piece. Think about what materials you might use and how you'll reinforce the skills. So this is kind of more like, this is how it applies. Why are we learning about resonance? Because this is what this looks like in your day-to-day job. And a lot of times this is a kid maybe after their surgical intervention, they've had some of this, and we're going to really work on getting that velopharyngeal port closed to get more of the oral airflow. So I just wanted, the read and review is different than what we've been doing. So I just kind of wanted you guys to be familiar with that. But reviewing these strategies and the process of this will prepare you for the quiz. So again, I can't reiterate that enough. Hopefully doing the read and review summary will help you prepare for the quiz. They're supposed to coincide. I think they do. So any other questions?
I have a question out of curiosity on like, what would be like an example, for example, like of a compensation strategy? Like, is it okay if because for example, in the observation that we had for this week, for example, the kid was sometimes saying D instead of G, D instead of G. So would that be a compensatory strategy? It can be a phonological process, but I'm just saying that, is that because he does it because he cannot say G very good because of the VPI, or would that be an example?
Well, I think in that they were trying to work on location and kind of getting that, if you do a G, your tongue comes up to the velopharyngeal port and feeling where that is. And they're trying to get the more oral airflow. So a lot of times we're trying to get the velopharyngeal port closed, and using that might be a strategy for that particular client. That doesn't necessarily work for everybody, but just what are some things that we would do? So like I said, blowing up a balloon. So I had a kid that was really, everything came out his nose, and when I'm talking about have it come out of your mouth, he wasn't understanding that concept. So we had to work on, what do I mean by getting the air out of your mouth? So like blowing up a balloon was the activity I used to teach that concept. And then, you take away the balloon. So he would do that a couple of times. And a lot of times it was really hard. He couldn't close off the airway. So even just doing something simple where I have them, if I'm working on reducing hypernasality, kind of feeling that there's some strategies in the treatment that kind of explain some of those things. But really what we're looking for, if we're trying to improve oral airflow, we're trying to reduce hypernasality. So that's the thing. The goal is written in a speech perspective. We want him to do these consonants, but really what we're trying to do is, because if you do a T or D and it comes out your nose, it sounds like an N. It doesn't sound like a T and D. Or if you're doing, a P or B and it's coming out your nose, it's sounding like an M. So that's
a compensatory strategy will be more something that helps you actually produce the right phoneme, not substitute. Substitute is an articulation error, correct?
I would say it's an articulation error, but sometimes you have to show the differences. Sometimes you might work on articulation for them to hear the difference. So it could have been in that particular, I'm trying to remember, I haven't watched it in a while. It could have been, he's trying to show the discrimination between the two. He's trying to talk about the location in their mouth so they can feel it. So when we're talking about closing that port off, the back of your throat is kind of more obscure for young children versus an adult who can understand those. So sometimes we do strategies to work on location in your mouth. Sometimes we do a strategy to discriminate between the sounds. And it might just be more of teaching the concept versus a compensatory strategy. Sometimes we're doing, like I said, sometimes blowing activities is to more talk about where the airflow is coming from, especially for reducing hypernasality. And a lot of times we're working on that after kids had their tonsils and adenoids out, then everything comes out their nose. Then you let that go on too long, and then now it's bad habit. So that's what I've seen too. It wasn't addressed right away, and it should have been, and it wasn't. Or sometimes they take too much off, and now guess what? We can't get closure. Sometimes, and then that's again, we might do speech therapy, try and work on that, and then they need to go back to the ENT, and we see, oops, this is a factor. That's a real, what we would call sometimes bad complication from surgery. So there's some of that, that it depends on the function of it. And that's why I say, if you're really not sure why you're working on something or why your supervisor recommended you to do that, then you should clarify with them so that you are clear on why she wants you to do that, or he, sorry, I always say she, I shouldn't do that. Why your supervisor wants you to do that. Okay, so yeah, read through the treatment on some of the strategies. There's lots on YouTube for some of this stuff too. Again, I have love-hate relationship with that, but, and if you're stuck, send me a message. I can direct you in the right way, okay? But this is going to cut off. So I appreciate you guys joining me, and I hope you guys have a good night.
Bye, thank you.
Thank you.